It's my pleasure today to speak about diabetes and kidney transplantation. I'm going to discuss this topic under the following sectors: why diabetes is an important disease, and the importance of disease comes from its prevalence associated with comorbidities and mortality, and I'll discuss it. What are the available transplantation options for diabetic patients? And then what about post-transplant diabetes, definition, risk factors, outcome, and management? And the correlations of donations and diabetes. Do we accept diabetic person to donate? Is donation associated with development of post-donation diabetes or impaired glucose tolerance? This will be discussed under this sector, and I'll end with some new guidelines. Let us to discuss why diabetes is an important disease. This is the last report of United States Renal Data System. Shows that through the years, diabetes mellitus is the leading cause for end-stage kidney disease. This is number of patients in thousands, and this is the prevalence per million. So diabetes, besides hypertension, glomerulonephritis, and cystic kidney disease, are the major causes of end-stage kidney disease, and diabetes is the leading cause through the years. Regarding the etiology, the newcomers each year, diabetes is still the most common cause of end-stage kidney disease. So diabetes is an important disease because it is a very common cause of end-stage kidney disease. Regarding the harvest of solid organ transplant in the United States, from January 1988 to the end of March this year, in the United States, they have the 629,000 transplants. The majority of transplants are kidney, liver, heart. Look at kidney and pancreas, 20,000, and pancreas alone, 7,000 patients. We discussed that diabetes is the leading cause of end-stage kidney disease, and we are expecting to find the majority of patients transplanted are because of diabetes. But the United States Renal Data System shows that the diabetes is not the most common transplanted etiology. Why? I think because of some discrimination against diabetics, because transplant centers are afraid of the comorbidities in these diabetic patients. So they are afraid of cardiovascular complications, and this is why when we have a diabetic patient prepared for transplantation, we exhaust ourselves, and the patient is subjected to thorough evaluation, including clinical examination, non-invasive stress imaging to diagnose or exclude coronary heart disease, and if there is a clue, we proceed for coronary angiography. And we are afraid of recurrence, but I want to stress upon recurrence. Even if diabetic nephropathy recurs, it recurs after a long period of time. And after recurrence, it will lead to graft failure after a very long period of time. So up to this moment, diabetes is a very important disease because it is the leading cause of end-stage kidney disease. Secondly, it's associated with cardiovascular outcome. Thirdly, the risk of recurrence still is there. Regarding the quality of life, if we compare patients who are transplanted and they are diabetic in comparison to non-diabetic, you will find here the quality of life is reduced in diabetic patients, and all the quality of life domains, including vision, hearing, speech, ambulation, dexterity, emotion, cognition, pain, and discomfort. All these domains are restricted in diabetic patients in comparison to non-diabetic patients. An interesting data that type 1 diabetes mellitus may be complicated with fracture, and it increases fracture risk after renal transplantation. Why? Because these patients are more prone to bone fragility and risk of fall. So why there is increasing risk of bone fragility? This is because of the environment of type 1 diabetes, or superimposed chronic kidney disease factors, or even transplant factors. So bone fragility because of advanced glycation in the products, insulin deficiency, low body weight, which accompany type 1 diabetes, and the renal dystrophy, vitamin D deficiency, or increased weight-bearing activity are added when chronic kidney disease or end-stage renal disease supervene. And after transplantation, we have new factors like the use of glucocorticoids or electrolyte disturbance like hypophosphatemia, which is not uncommon, especially in polyuric patients after transplantation. So all these factors can lead to increasing risk of bone fragility, and increasing bone fragility may lead to increased fracture after renal transplantation. The same risk of falls because of neuropathy, hypoglycemia, amputation, visual impairments. All these factors accompany type 1 diabetes. Myopathy, acidosis, vitamin D deficiency, orthostatic hypotension, and malnutrition are added when chronic kidney disease or indecisional disease supervene. And then after transplantation, we have glucocorticoid-induced myopathies, etc. So all these are risk factors that increases the risk of fall, and increasing risk of fall leads to increasing risk of fracture. Again, type 1 diabetes after kidney transplantation, there is an increased risk of fracture because of increasing risk of bone fragility and risk of fall. Again, diabetes is a very important disease because it is very common cause of end-stage kidney disease. We are afraid of accompanying comorbidities like cardiovascular, risk of recurrence is there, limited quality of life domains, and increasing fracture risk after transplantation. And this is a very important issue as well. Look at the survival. These are the diabetic patients. In diabetes, survival is significantly lower in comparison to other etiology. This slide carries a glimmer of hope because before 2000, this bar reflects the survival of non-diabetic patients after transplantation. And this is the survival, 5-year survival percentage of diabetic patients. You can see here there is a great difference. So diabetic patients have significantly lower survival rates after transplantation. But by the years up to this year, you find here this difference is diminished, and there is approximation of diabetes and non-diabetes, and this is because of improvement of the patient care and the following multidisciplinary team approach. So again, diabetes is very important because it is a very common disease associated with comorbidities, a risk of recurrence, a limited quality of life, a decreased patient survival, and it needs special care and multidisciplinary team approach. What about the available transplant option for diabetic patients? I think it is summarized here. We have simultaneous pancreas and kidney or combined pancreas and kidney. This is a modality. I think this is the best modality for type 1 diabetes. And then we have pancreas after kidney. Also, it is an option for type 1 diabetes or pancreas transplant alone. I want to emphasize and declare that pancreas transplantation is not an easy task. Why? Because it is a complicated surgery. Because we would like to anastomose enteric, the endocrine and exocrine function of the pancreas. There is increasing risk of thrombosis, increasing risk of leak. So, and the anastomosis is either enteric or to the bladder. But I want to say, if we have combined kidney and pancreas or simultaneous pancreas and kidney, we can monitor immunologically pancreatic function by monitoring kidney function. And even if we have kidney biopsy showing rejection, we can treat kidney, and kidney will be a mirror for the pancreatic changes. Here, this study shows that simultaneous kidney and pancreas is the best modality for type 1 diabetes. For type 2 diabetes, still the best transplant option is still uncertain. However, at the end of this presentation, I show you what is in the guidelines regarding this issue. Regarding the fracture risk after renal transplantation, as I mentioned in the first sector, that type 1 diabetes has an increased risk of fracture after renal transplantation. If we look at the non-diabetic kidney transplant recipients, this is the fracture incidence of fracture per 1,000 patient years, 7.2. And if they are diabetic and receive kidney transplant alone, this is the incidence, 15.8 per 1,000 patients. But if the pancreas is there, the risk, the incidence decreases from 15.8 to 12. So it seems that pancreas transplantation offers advantage regarding the fracture. And here, if we compare the kidney and the pancreas versus kidney alone, we will find the fracture incidence rate is significantly higher if the kidney is transplanted alone in comparison to kidney and pancreas. And this is the same in all the sites. This is the simultaneous pancreas and the kidney, and this kidney alone, you'll find the fracture is higher if the transplantation is kidney alone. This slide summarizes the different outcome in simultaneous pancreas and the kidney. I'm not going to discuss this sector. So, regarding the post-transplant diabetes, here I want to stress upon the best is to say post-transplant diabetes and not new onset diabetes after transplantation. Why? Because the patient may not know that he is diabetic. And because of end-stage kidney disease, plasma glucose decreases. So we can assume that the patient is not diabetic while he is a diabetic patient. So, and this is why post-transplant diabetes is more accurate terminology. But you can say, if I have the plasma glucose is normal after transplantation for many years or many months, and then the patient develops hyperglycemia that persists, so this is new onset diabetes after transplantation. Yes, I agree with this concept, but post-transplant diabetes is an accurate for early and delayed period after transplantation. And this is why the proceeding from this international consensus meeting recommend changing terminology from new onset diabetes after transplantation back to post-transplant diabetes mellitus, PTDM. How to diagnose it is a very simple issue. It is the same like diabetes in general population. Look at the fasting plasma glucose, random plasma glucose, 2-hour plasma glucose, or hemoglobin A1C. If you have fasting plasma glucose equal or exceeding 126 milligram per deciliter on more than one occasion, or the random plasma glucose exceed 11.1 plus symptoms, or the 2-hour glucose after a 75 gram oral glucose tolerance exceed or equal 200 milligram per deciliter, or A1C exceeding 6.5%. This is the definition and diagnosis of post-transplant diabetes mellitus. Here I have a question. Does measuring hemoglobin A1C in the first year post-transplantation is an accurate for screening and diagnosis of post-transplant diabetes? The answer is no. Hemoglobin A1C shouldn't be used alone to screen for diagnosis of PTDM within the first year after transplantation, and this is because of limitations as shown in another study showing different sensitivity, specificity, predictive values for different cut points of A1C. So the best is to monitor plasma glucose and to look at A1C and not depending on A1C alone. A very interesting point that was declared from this consensus is the duration, the period of after the period where we define hyperglycemia. If we have hyperglycemia within the first week, this is not diabetes, it's just post-transplant hyperglycemia. Even if hyperglycemia is within the first 1.5 months, 45 days after transplantation, that doesn't persist, we cannot say post-transplant diabetes. Again, to say post-transplant diabetes, hyperglycemia should persist beyond 45 days after transplantation. And whenever we diagnose hyperglycemia in the first week of transplantation, we should think of insulin, because different studies show that early insulin use is associated with better islets and beta cell preservation. If you diagnose hyperglycemia after the first week and beyond 1.5 months, think of insulin and oral antihyperglycemic agents. And if you diagnose it after 1.5 months, follow the same regimen of type 2 diabetes, lifestyle modification, oral antihyperglycemic agents, and the last resort is insulin. What about the epidemiology? Is it a prevalent disease? Yes, it is prevalent, and the prevalence is, or the incidence after transplantation is very variable, from 10 to 70%. And in this study shows normoglycemia in 59% of patients, and post-transplant diabetes was diagnosed in 12.5%, impaired fasting and impaired glucose tolerance in 8.9%. Impaired glucose tolerance means that post-branded plasma glucose is between 140 to 200 milligram per deciliter, and impaired fasting in 12%. Impaired fasting means plasma glucose between the fasting plasma glucose is between 100 and 125. This slide shows in this study the incidence of post-transplant diabetes within this period after transplantation. Look here, this study included 481, and diabetes was diagnosed after transplantation in 108 events, and all these patients were not diabetic before transplantation. Again, here the post-transplant diabetes or new onset diabetes was diagnosed in 30% of cases. In the present, if we compare post-transplant hyperglycemia or post-transplant diabetes with no diabetes or no hyperglycemia after transplantation, we'll find the cardiovascular problems and disease are more common association with post-transplant diabetes. And here you can see the survival curve of the graft for both patients who are diagnosed to have diabetes after transplantation or normoglycemia. The presence of post-transplant diabetes is bad news and associated with lower graft survival in comparison to normoglycemia. So the consequences of post-transplant diabetes are lower graft survival and function, lower patient survival, and high cardiovascular risk. Not only kidney transplantation, but also liver transplant recipients, showing that the presence of type 2 diabetes pre and post-transplant are associated with increased risk of adverse post-transplant outcomes. Up to this moment, diabetes is a very common disease, and it is the leading cause of end-stage kidney disease, associated with comorbidities. Even the survival may be affected, and the fear of recurrence and limited quality of life in comparison to non-diabetics. For the transplant options available for these patients, kidney transplant, pancreas, pancreas after kidney, and combined kidney and pancreas. And I mentioned that the best option for type 1 diabetes is to proceed for combined kidney and pancreas, or pancreas after kidney if the patient has a living donor. The definition of post-transplant diabetes is the same like the diabetes in general population. It may reach the average 30%, from 10 to 70%, and then we discuss some issues related to the importance of the post-transplant diabetes because it's associated with solid outcome problems. Now I'm going to discuss the risk factors for post-transplant diabetes. One of the important risk factors is obesity. So the higher the body mass index, above 35, the higher the risk for development of post-transplant diabetes as shown in this slide. Visceral fat is a very important risk factor, and this study, visceral fat diagnosed by DEXA scan, is associated with increased risk of impaired glucose metabolism than body mass index after kidney transplantation. And this slide shows 4 risk factors for the development of post-transplant diabetes. Here, age above 50 years, the pre-transplant impaired glucose tolerance is associated with higher risk of development of post-transplant diabetes. Body mass index above 25 kilogram per square meter. An interesting factor is autosomal dominant polycystic kidney disease. I'm not sure why autosomal dominant polycystic kidney disease is associated with increasing risk of development of post-transplant diabetes. It may be due to presence of cysts in pancreas, I'm not sure. And here, the more the risk factors, the more the development of post-transplant diabetes. Regarding the immune suppressive drug, this slide shows the different immune suppressive drugs and trends in their use in United States. This is one of the recent reports early this year. Cyclosporin is vanishing, tacrolimus replaces cyclosporin, azathioprine is vanishing, MMF-based regimens are increasing, mTOR inhibitor still very low to be used, and here steroid avoidance is witnessed in 1/3 of patients. So up to 1 year post-transplantation, 2/3 of patients are maintained on steroids. All the maintenance immune suppressive drugs, calcium inhibitors, mTOR inhibitors, and steroids are associated with increased risk of diabetes mellitus. We can say that all maintenance immune suppressive drugs can lead to increasing risk of post-transplant diabetes except azathioprine and mycophenolate mofetil. So azathioprine and mycophenolate mofetils are not associated with increased risk of diabetes. Why calcineurin inhibitors are associated with increasing risk of diabetes? Because calcineurin is needed for the action of insulin. So when we block or inhibit the calcineurin, we inhibit the mechanism of insulin. Here, these are the different risk factors, the diabetogenic potential and the diabetogenic effect, and the treatment for post-transplant diabetes. So obesity, hepatitis C, cytomegalovirus lead to insulin resistance. Old age, gender, male, genetic, steroid, and sirolimus may increase the risk, and cyclosporin FK reduces insulin secretion. So all these are risk factors for the development of post-transplant diabetes, and this is the diabetogenic effect. Sirolimus-based regimens are associated with even more higher risk of other regimen, as you see in this slide. Why mTOR inhibitor is associated with diabetogenic potential? As you see here, this is insulin substrate, and this is the insulin receptor. So both calcium inhibitors and mTOR inhibitors lead to defect in the insulin action. We should concentrate in patient treatment and both in patient treatment considerations. So if we are in this period, immediate post-transplant period, you will find the concern is the use of high-dose immunosuppressive drugs. And here we would like to monitor frequently and to use intravenous frequently. And in the first week of transplantation, increase nutritional intake, steroid dose weaning, all these are concerns. High-dose immune suppression is common, and the insulin requirement may change daily due to renal function changes and increased nutritional intake. So we should be careful about that. Even in later period, we may be afraid of rejection and the management of rejection that necessitate further monitoring and treatment of diabetic state. In our experience at the Urology and Nephrology Center, Mansoura University, if we compare, when we compare steroid-free regimen versus steroid maintenance regimen, including tacrolimus and mycophenolate mofetil, here diabetes is 5% in the steroid-free regimen and 15% in steroid maintenance regimen. This is a very interesting study because it shows in a double-blind fashion that the use of small dose of steroid is not so harmful. So this is, if we have a patient with immunological risk, we can use steroid. Regarding the rejection and its effect and its impact on the post-transplant diabetes, as you know, rejection needs high-dose steroids, so this is another risk. And this study shows in a multivariate analysis, intensified rejection therapy, carvedilol, kidney donation from male donor, allopurinol use, central thymbetholytic drugs, higher body mass index, higher age are associated with the increasing risk of post-transplant diabetes, and you can look at the individual risk factor for each of these criteria. So intensified rejection therapy associated with a 3.5-fold rise in the relative risk of the post-transplant diabetes. Another important factor that was addressed in one of our studies, that hepatitis C positive serology increases the risk of post-transplant diabetes. Look here, 85 patients out of 315, all these are diabetics, and 85 of these 315, out of 315 hepatitis C positive recipients, 85 patients developed post-transplant diabetes. In comparison to approximately 600, only 87 show post-transplant diabetes in hepatitis C negative serology patients. So this means that hepatitis C is another added risk factor for all risk factors that I mentioned. Up to this moment, I mentioned that the obesity, visceral obesity, old age, polycystic kidney disease, use of steroid, cyclosporin, tacrolimus, mTOR inhibitors, the hepatitis C, all these are independent risk factors for the occurrence of post-transplant diabetes. Even the associated hepatitis C in liver transplant increases the risk of diabetes. Gene polymorphism, all these single nucleotide polymorphisms are associated with increased risk of the new onset diabetes after transplantation and impaired glucose tolerance. Another two genetic polymorphism, KCNQ1 and KCNG11, these gene polymorphisms are associated with increased diabetes in Asian Indian population. Another interesting factor is hypomagnesemia. The lower the serum magnesium, the higher the risk for post-transplant diabetes, especially if serum magnesium is less than 2 milligram per deciliter. Patients who develop inpatient hyperglycemia after any admission is another risk factor for post-transplant diabetes. Again, just to summarize, the risk factors of post-transplant diabetes include obesity, old age, polycystic kidney, visceral obesity, immune suppressive drugs other than azathioprine and MMF, so steroids, cyclosporin, tacrolimus, everolimus, sirolimus, all these are associated with increasing risk of post-transplant diabetes, some genetic polymorphism in patient hyperglycemia and hypomagnesemia. How to manage? As I mentioned before, if we diagnose hyperglycemia in the first week of transplantation, we should think of insulin first. And after that, we can follow the lifestyle modifications and other drugs. And the recommended drugs, as you see in this slide, is using sitagliptin, vildagliptin, glimepiride, nataglinide, ribaglinide, glipizide, and metformin may be used if estimated GFR is above 60 ml per minute. These are the different drugs, as you see, and the different mechanism of action. So glutathione and insulin can improve this pathway. Is sodium glucose transporter inhibitors leads to glucosuria, but I am not convinced by their use in transplantation, especially if there is CKDT or estimated GFR is less than 60 ml per minute. Because if estimated GFR is less than 60 ml per minute, I think these drugs are not effective because it needs good kidney function to have glucosuria. And secondly, we are afraid of lactic acidosis. The insulin sensitizers lead to improvement of the muscle uptake, and insulin secretagogues leads to release of insulin from pancreas. When we prescribe any of these glucose-lowering agents, we should know the mechanism of action, and we should know the risk of hypoglycemia. I think glenide, biguanides, and glutazones, biguanides, glutazones, DPP4 inhibitors are associated with low risk of hypoglycemia. And these are the other drugs with their modification according to different estimated GFR. And this is one of the important cartoons showing in a heat map. If you find green color, it's perfect. Yellow color needs modification. Red color is contraindication. So if we look at metformin, if the estimated GFR above 60, no problem between this range modification. But this study was published in July 2014, and after this date, we have some reports showing that if we use metformin in lower GFR, we find high mortality. So I believe that the FDA recommendation is nice, very nice. So if creatinine is above 1.5, serum creatinine above 1.5 milligram per deciliter in men or 1.4 in women, don't use metformin. These are all the medications that are not currently used. If you use these drugs, you look if it's green. For example, this drug can be used in all estimated GFR. This is DPP4 inhibitor. You will find here linagliptin needs no modification. If you use sita or vildagliptin, look at the modification, just modify the drugs. And this color denotes that no available studies for these drugs. A very interesting study shows that if we use basal insulin earlier, at the end of the day, you will find vanishing diabetes because basal insulin preserves islet cell, and this is in comparison to the control patients that were treated as in a regular fashion. What about our experience in Mansour? This is our cases. We have the incidence of post-transplant diabetes, cumulative incidence 22%. The risk factors for post-transplant diabetes, including old age, positive family history, obesity, and cumulative steroid dose. And the diagnosis of post-transplant diabetes is associated with higher incidence of proteinuria, graft dysfunction, development of diabetic nephropathy, hypertension, ischemic heart disease, stroke, neuropathy, retinopathy, and pancreatitis. And this is one of our cases. This patient, the etiology was not diabetes, the etiology of renal failure was not diabetes, and after transplantation, the patient develops post-transplant diabetes that is complicated by the shown histology of diabetic nephropathy after transplantation. So this is de novo diabetic nephropathy after transplantation and not recurrent diabetic nephropathy. Again, Post-transplant diabetes mellitus is an important complication that contributes to increased morbidity and mortality of transplant patients. Early recognition of patients at risk is essential. Early insulin treatment of post-transplant hyperglycemia is important to preserve beta cells. When post-transplant diabetes mellitus is established, glucagon-like peptide 1 and DDP4 inhibitors may be the first line of treatment. What about the donation? This is in cadaveric organ. The older the age and the presence of diabetes in the donor is an important risk factor for this is patient survival, for reduction of patient survival and reduction of graft survival. This is a cadaveric, and here in Japan in one center, this study included 444 patients. All patients are subjected to oral glucose tolerance study, and normoglycemia was documented in 373. Impaired glucose or glucose intolerance was diagnosed as diabetes in 27 patients, and impaired glucose was in 44 patients. All these were considered donors. So in this center, they accept diabetes so long as there is no complication. But in all literature and our practice would decline, and we consider diabetes as a contraindication for donation. And this is the same. The diabetes mellitus is contraindication to donation, other than in exceptional circumstances, and the suggest impaired glucose tolerance is not an absolute contraindication, and we don't accept to take kidneys from any person diabetic or impaired glucose tolerance. So this is our practice. Regarding glycemic control after donation, so we have donors and then followed up after donation. We find that impaired fasting and impaired glucose tolerance were found in 15.4% of those donors, and diabetes mellitus in 11%. Risk factors for this glycemia included age above 50 years, body mass index above 30, positive family history. So whenever we have donors with these risk factors, we should address these risk factors and educate these donors not to gain weight after donation, and follow the good lifestyle, walking, physical exercise, avoiding smoking, and avoiding gaining weight. So it is very important to continue follow up donors and educate them regarding the lifestyle. One sector of these guidelines regarding transplantation in diabetic patients with this is one of the sectors. Is there a benefit to undergo renal transplantation for patients with diabetes and stage 5 chronic kidney disease? The answer, for type 1 diabetes, the guidelines suggest living kidney transplantation or simultaneous pancreas and kidney transplantation is the best modality to improve survival of a suitable patient. This is suggestion based on weak evidence, and they suggest against islets. Why suggesting against islet? Because to have islet, we should harvest the islet from multiple donors, and the technique is not easy, and then the patients need immune suppression. So at the end of the day, the islets are not so practical because the survival of islets is not satisfactory. And again, they suggest pancreas after kidney if you have a patient and you proceed for living donor transplantation, and you can list him to a pancreas. Why? Because it improves the metabolic profile of the patient, and it improves the and prevent the development of hypoglycemic unawareness. Again, pancreatic transplantation is not an easy task and needs a good health to proceed for the pancreas transplantation. This is a very nice algorithm. If the patient is diabetic, end-stage kidney disease because of type 1 diabetes, the patient has a living donor available, go ahead for preemptive living donor kidney transplantation, and you may consider pancreas after kidney. So this is a nice approach. Here I have a question from Professor Samir. Suppose that you have a patient with type 1 diabetes and coming to you with his brother, how can you proceed? So my answer, if the brother is 50 years, I'm not, I don't consider there is any risk, added risk. But if the brother is young and the family history is showing many members in the family complicated with type 1 diabetes and the consequences, I can decline this related donor. But again, there is no strong evidence for that. So if we have type 1 diabetes with end-stage kidney disease with living donor, proceed for living donor kidney transplantation, because the outcome will be superior in comparison to leaving him on dialysis. And then you can consider cadaveric pancreas later on. If there is no living donor, assess his status. If there is no comorbidities, proceed for cadaveric simultaneous pancreas and the kidney. And if there is cardiovascular or multiple comorbidities, just it is sufficient to have cadaveric kidney transplantation, because pancreas transplantation is not an easy task. So this is the guideline approach for type 1 diabetes mellitus end-stage kidney disease patients. For type 2, the recommendation is against pancreas or simultaneous kidney and pancreas, so just kidney alone for the type 2 diabetes. And the recommendation shows that diabetes in itself shouldn't be considered a contraindication to kidney transplantation in patients who otherwise comply with inclusion and exclusion criteria for transplantation. So it's better not to deprive this patient from transplant option, because in comparison to dialysis, transplantation offers best level of quality of life. Again and again and again, transplantation needs teamwork, and even the care of diabetic patient needs comprehensive care. And this is what we learned in the at Urology and Nephrology Center, Mansoura University, that was founded by Professor Ghanem, and I am very proud to work under his supervision. And this photo was taken on this month, on the 17th of December. The last statement, we should work in a successful environment. To work in successful environment, we should speak about idea, forgiving others, and work in a team. And if you will feel more happy if the others are successful too. Thank you for your attention, and I'll be happy if you have any questions and any queries, just send it to my email your question. Thank you very much.